All right. Hello, everyone, and welcome. This is part two of a series entitled Supporting Clients Preparing for Care at the End of Life. We are so lucky to be joined again by Jessica Empeño. She is with Compassion and Choices, and her part one is amazing. So if you're watching the replay or you're here live and you haven't seen it, make sure you go grab that so you can watch it. We were saying at the beginning, it is not a prerequisite to be watching this or to be here, but it certainly is going to add even more depth to your learning. So, Jessica, I'm going to hand it over to you. You can share any other intro stuff that you would like, and we can dive in.
Absolutely. Thanks so much, Jenny. Hello. It is a pleasure to be here with you again today, and I want to make sure to introduce my right hand, Megan Williams, who is also with Compassion Choices, part of our team. So she will also chime in from time to time, and you definitely will see her in the chat helping with resources and questions and things like that. Please know that the goal is to provide information that is useful and practical to you. So if I say anything that is unclear or you want to dive a little bit deeper or you want to go down a rabbit hole on something else, just let me know, please. This is definitely for you all and hopefully and to support your work with clients. So, just to share a little bit more, I'm actually based in California. I'm in Southern California, and I have been a medical social worker for about 25 years, working in end-of-life care, in healthcare, in the community, direct care, leadership and admin positions. So I've had the neat opportunity to do a lot of different things, but this work, helping to support others in their work, and these topics are really my area of passion. And so I hope this is helpful. Before we, really get started and dive in today, I want to just take a moment to um, first, I want to check in from the previous session, part one, and see if there were any particular questions. I know not all of you were on that one, but if there were any questions or anything that came up that you wanted to touch base on before we move forward.
No one reached out to me with anything. We'll give folks a second if they're typing in the chat, but yeah.
Okay, sounds good. I also, before we jump in, I just want to acknowledge, as Jenny shared before we got started, there's a lot of life going on in big ways and in small ways, and there's a lot happening in the world and in our communities right now. And just acknowledging that, that weighs on us. That is part of what we are coping with and dealing with. As we also try to support others. And sometimes it's easier to support others than to take care of ourselves, as Megan often reminds me. And so I just want to, just acknowledge that and, hope that, or encourage you really, hope that you are taking care of yourself in all of the things that are happening out there. So today we are talking a little bit about end of life options and care. And we're going to dive a little bit more into some of the resources and the programs and the things that are good to be aware of as we are supporting people and having these conversations. And I think one of the most common things that I hear is, well, how do I start the conversation? Where do I start? These can be hard things to talk about. And so what I want to start with is just kind of grounding us in what we're really wanting to do with folks is help them kind of narrow in on what matters most to them. And really what we're trying to get at is what matters most at the end of life, but really we're trying to understand who this person is, right? And so when we are having these conversations, there are really three main things that we can focus on. And that is first starting with what is this person's wishes regarding their care, regarding treatments, their care options, their preferred level of interventions. What are their goals and their priorities, but also what are their concerns? What is the reality of their situation? Basically, what we're trying to figure out is where are we starting, right? And what matters to them. And then the second thing that we really want to focus on is, these conversations have to be a whole lot more than, do you want a DNR, right? There are a lot of options out there, different levels of care, different treatments available, things that people may or may not want. People think things that people may feel obligated, that this is what the doctor said, so this is what I guess we're going to do. And they don't even realize that they have the option to say no. So we want to have conversations about, have there been things that have already been decided? Decisions you've made, things you've already talked about, things you've already put into place. Do you have an advance directive? Let's start there. Have you chosen someone to be your surrogate decision maker? I had a consultation with a family just earlier this morning who they really wanted to talk about end of life options, and they wanted to know, what is she eligible for? And before answering those questions, I said, well, let's start by talking about advance directives. Do you have one? And they didn't. And so this idea of, well, have you had conversations about what matters to you, what type of care you want, who's going to make decisions for you, if and when you are unable? That wasn't even something that they had thought about. So no assumptions, just asking, right? What have you already talked about? What have you put in place? And then what's unclear? What do they understand about their situation? What do we still need to talk about? What is good to review? What is still outstanding for us to decide on? And so focusing on these three questions will then help give you a sense of where you're starting and kind of where to go next. And I want to just acknowledge that as we go through these different care options that we're going to talk about, that there's a big difference between what care and options and treatments, interventions, medicines, services, right? This applies to so many different things. What things are available versus what's actually offered to the person, and then what things they accept, what they want, right? So the availability of end of life care programs specifically, in the United States has grown significantly through the years. And there's a big focus on quality of life and care for people that are living with serious illness. But many people still go without those things. And is it because it wasn't available to them, because it wasn't offered, or because maybe they didn't understand it, or they didn't want it and accept it? So there's a lot of factors to consider there. And so this is something that we really want to just keep in mind as we're talking about options with folks. So at the end of life, many people wish to focus on comfort care. And this is a really common term. It's used a lot. It's even used as in a euphemistic kind of way. Very often we hear people talk about comfort care, and maybe what they're actually referring to is hospice. So it's not often described or defined, and people don't usually stop to say, what is comfort care? Tell me about what that is. So I want to start there by just kind of normalizing that we don't really talk about and define what it is very often. And so comfort care is when the focus of care or the goals of care move away from life prolonging, maybe aggressive interventions. So instead of focusing on a cure, on extending life, we are instead kind of switching that focus to focus on comfort and quality of life. And so the most important thing is not aggressively trying to treat or cure this disease. The most important thing becomes making sure that this person is comfortable. Comfort care does not mean no care. Comfort care is not a last resort when there's nothing else we can do. Sometimes comfort care can actually be even more care and more support than what the person has had before, right? It's about aggressively making sure that the person is comfortable. And I want to remind too that just as quality of life means different things to different people, so too does comfort and what being comfort means, what brings comfort to somebody, even what qualifies as discomfort and the level of discomfort that somebody is okay with. And so, what we want to ask people is, are you experiencing anything that brings you discomfort right now? Which is much more inclusive and comprehensive than saying, do you have pain? What's your pain? Rate it on a scale of 1 to 10, right? Because it may not be physical pain and hurting that they're experiencing. It could be, maybe they're most concerned that they're not sleeping well, that they feel restless or anxious, right? That they are having trouble feeling like they're catching their breath. All of those things also cause discomfort and then are things that we're also focusing on. And so I don't have to tell you that the emotional and physical experience is also, we really need to make sure that we're focusing on that psychological, emotional, spiritual, psychosocial aspect of this as well. So comfort care does and should include spiritual support, emotional support, but also that practical support. How do we get you a little bit more help in the home so that you can relax and you're not overdoing it, right? That sort of thing. So that is comfort care. Now, comfort care can be a euphemism and often is for hospice, but hospice is its own type and model of care. So, hospice in the United States, now hospice is different in different countries, if not all countries even have hospice. But in the United States, hospice was actually developed as an all-inclusive model of care. It was developed by Medicare in the 70s. And it started as kind of an experiment, right? What happens if we provide all these services to people at the end of life? And it is one of the few medical programs that is paid differently than all others. It is all inclusive, meaning that hospice providers receive a daily rate for all of the services that a hospice provides. So it's not fee for service, it's not value based right now, although they're exploring that. It is a comprehensive service. So all of the staffing, the medications, the equipment, the supplies, everything that a hospice program provides is meant to be covered in this daily per diem rate. Hospice is largely considered the model for quality, compassionate care for people that are facing a terminal illness. It combines medical care with care coordination, with pain management and symptom management, along with emotional and spiritual support, everything being very tailored, very personalized. Medicare actually emphasizes how important it is to make sure that the care is personalized to that individual's needs, to their situation, but also to that of whoever the patient identifies as their family. So that support system becomes the primary focus. And honestly, sometimes we are doing more work supporting the family and the loved ones and the caregivers than we are the patient, depending on the situation. And so hospice really focuses on caring, not curing. Hospice is a very powerful support, often more support than people have ever had, because now they have a full interdisciplinary team that are not only supporting them, but are available 24/7 for questions and consultation. Medications and equipment are not only being provided easily without all that extra work of trying to coordinate that, but it's being delivered to the house for you. You've got people that are coming into the house. So for a lot of people, to be honest, it can be a little overwhelming at first because they're not used to getting this much attention and having people calling and checking on them every day. But it's an amazing source of support that unfortunately a lot of people don't accept or choose or even know about until they're in the final days and weeks of their life. And so we have a lot of people that choose hospice at the very end. So you'll see on the screen here the list of all of the different things that are a very standard part of hospice. This is only part of it. It's a lot of things that hospice does, and I'll just sum it up by saying the hospice team, they are experts in end of life care. So they can help guide and support people through that journey, whatever that journey looks like for them. I do want to note that the last bullet here, you'll see that hospice is provided at home. And I put that in quotes because it's wherever home is for that person. So if the person is in assisted living, if they're in a residential care setting, skilled nursing, or they're in an apartment or they're in an RV, I've cared for patients living on a boat, people under a bridge. Wherever home is for them, that's where hospice goes. And with more and more telehealth capabilities, we are also able to support people more frequently and keep that better kind of touch with them um, as we support them. So hospice, eligibility for hospice is for people who have been given, as our best estimate is if the disease runs its normal course, but also based on the patient's goals of care, meaning they are electing to no longer continue aggressive treatments, or they're at a point in their disease where that's not even an option anymore, approximately 6 months or less to live. And that is part of the core eligibility criteria, and two physicians actually need to attest to that. But also, more importantly, to be eligible for hospice, this has to be something that the patient or somebody on their behalf is electing. So saying, yes, I understand that this is what hospice is, this is what I want, and I am giving up the option for those kind of aggressive. So, no more blood transfusions, no more chemotherapy, those kinds of things. Um, the details about what other kind of services and treatments and medications might be offered and available to somebody really do depend on whether or not that hospice program chooses to pay for it themselves or feels that that's appropriate within the care plan and the goals of care. But in terms of what Medicare looks at, Medicare says it's up to the hospice. We give you this daily rate. How you choose to spend it, what you choose to do with it, what services you provide, that's up to the provider. Um, Also, in addition to the interdisciplinary care team and the different environments that it's provided in, I want to mention too that in terms of insurance, hospice is one of the few benefits where it is covered at 100%. So if somebody has Medicare, um, it will be covered at 100%. Now, it is also what is called a carve out in Medicare, which basically means that even if a person has a Medicare HMO plan that they've chosen, Medicare bypasses that HMO and is billed directly to Medicare. Also one of those things that's being experimented with a little bit. The same goes with Medicaid. Medicaid pays for hospice services 100%, no copay or anything like that. And if somebody has private insurance, so they don't have a Medicare or a Medicaid, if they have commercial insurance, like through their employer, it depends on their plan. And so what we do in hospice when somebody is referred to us, actually hospice will tell you exactly what your insurance is and what it covers. That is not something a person should have to figure out on their own. Call the hospice. Part of that intake process is going and calling insurance, verifying eligibility, and notifying upfront. They're actually required per CMS regulations to notify an individual upfront if they have any sort of deductibles or copays if they have a commercial insurance plan. Okay. Palliative care.
Jessica,
Yeah,
can I interrupt real quick?
of course.
So, this is a very specific question because it's something that happened to me when I was a caregiver for my dad, but I think that it's helpful for other people to know if this is still a thing. So, this was back in like 2010, 2011-ish, but my dad actually went on hospice and then came off of hospice.
Mhm.
And the details don't really matter, but he then lived until 2020. So it was like he was not dying, but it was this. interesting loophole because I can't even remember the medical stuff that was happening at the time, but we made the agreements of stopping curative care. A clinician gave him the 6 month thing. I don't remember why, but he then got this whole influx of support and resources, which actually helped him get better. And so that's why I'm asking it because it was like this weird, crazy loophole. We were in Boulder, Colorado, and so it was like I think it was we just had better support and access than a lot of other folks
Yep.
to know that we could do that. And so I'm curious. I can see your reaction, and you're very like I can see that you're enthusiastic about it, but I'm curious if there are things you want to share about that.
Yeah, there's a lot of, I mean, we could spend the whole day just talking
I
about
know.
hospice and the logistics and how it all works. But bottom line is, it's not uncommon for people to be on hospice and then to do better. Because one of the first things that they do as the part of the onboarding of hospice is we look at everything a person is taking. I always told families, everything you put in you and on you, we're going to review. And a lot of times we let go of a lot of those medications that are not serving anyone anymore. Sometimes it's the first time we're doing a really comprehensive medication reconciliation, and we're focusing on what medications does a person need to really support their quality of life. And so sometimes people, they perk up, they're feeling better. But also, we don't really have a true crystal ball. We're making our best estimates, right? Prognosis is sometimes more an art than it is a science. And so, if we don't quite get that 6 months right, that does happen. So people do transition off of hospice for a variety of reasons. It could be that they live longer. It could be they're improving. It could be that they said, you know what, there's this treatment. I actually want to go give it a shot. So they sign off of hospice. They can always sign back on. There are no longer, originally there were, but now there are no limit to the benefit periods within Medicare. You can have an unlimited number of benefit periods with Medicare and Medicaid. Um, so what happens is while somebody's on hospice, part of the requirements of the hospice team is to, as much as we try to be patient-centered and positive and encouraging, we really have to chart to the decline. You have to show all the ways that the person is declining and things are getting bad, which sometimes is counterintuitive, especially for psychosocial clinicians. But we're looking at how much are they eating in a day, and are we seeing that trend downward, right? Are they losing weight? Are they losing body mass? All of those kinds of things that would show us that a patient is declining. Now, if we have somebody who is getting stronger, they're gaining weight or they're not, or they're maintaining their weight, we might start to question whether hospice is still something they're eligible for. And so the team has to review that every 6 months. And at that 6 month mark, they recertify their eligibility. And if not, there may be a conversation with the patient and the family to say, hey, this is kind of what things are looking like here. And so people do come off for a variety of reasons, or they get recertified and they stay on. And sometimes people meet that criteria and they're on hospice for a year, 2 years, longer, depending on their disease process. So it's very specific to a person's situation.
Yeah, and I appreciate you expanding on that because what you're sharing is, hospice is not a death sentence, and it can be such an incredible support source of support and services. And so, if we have folks in our own lives or the clients we're serving who could benefit from it, it's worth at least getting the evaluation done to see
Yeah.
if it can help.
Yeah, the evaluation is no cost ever. And there's no obligation, but the sooner that somebody has that support, the better. And there's other elements like the bereavement support that goes on for 13 months after the person dies. So there continues to be that support. A lot of hospices have really adopted integrative therapies into the services. So you might also have aromatherapy, music, massage, pet therapy. Some hospices are starting to work with doulas and bring in that additional support. And one other thing I want to add really quickly, and before we wrap up with hospice, is there are a lot of misunderstandings and myths and misconceptions around hospice, that hospice will come in and take over, or they come and take somebody away, or that hospice is a place. Hospice is meant to be provided in the home. However, there are some hospice programs that have what maybe they'll call a hospice house or a hospice hospital. And generally, those are reserved for people that are in crisis. So if somebody is, let's just say, for example, we are struggling to get somebody's pain and symptoms under control in the home setting, we might move them to the hospice house where they get that 24-hour intensive support. And they might live their final days there, or they might get stable and go back home. So there are different levels of care in hospice. In addition to that inpatient level, we might also have what's called continuous care, meaning we bring the nurses into the home, and for maybe a period of like 8 hours, we have somebody at the bedside. But hospice in and of itself, while they are available 24 hours a day for support, so you can call at 3 in the morning with questions, they are not 24-hour care. And you all know realistically, that's what a lot of people need. They need that hourly custodial type of support. And when people find out that that's not what hospice is, they're, oh, well, then never mind then. So there are a lot of tremendous things, including, people that can really help with that care coordination and get those other services in place and help people figure out what they're eligible for. Okay, so keeping us going, I want to talk a little bit about palliative care. Talk about a program where there's a lot of misunderstandings and misconceptions, especially how palliative care is talked about in relation to hospice and end of life care. A lot of people do tend to use palliative care as kind of a euphemism for end of life care. But palliative care, what it actually is specialized care for people that are living with a serious illness. It is available to people at any age, at any stage in their disease, with really any goals of care. So it can be provided alongside people that are seeking curative, aggressive treatments. It can be provided at the end of life, right? So there's a lot of different ways that palliative care can kind of show up for somebody, but the goal is to improve quality of life for patients and for their families. And so depending on where and how palliative care is provided, it's most often available in a inpatient setting. Community-based palliative care is a bit harder to find. And part of the reason for that is there is no standard palliative care benefit. There is no Medicare or Medicaid standard benefit. Now, some states, Hawaii, California, New Jersey, have implemented amazing palliative support through their Medicaid programs. And so it is more available. But again, it's kind of all over the place. So palliative care really focuses on managing symptoms, coordinating care, and really focusing on end of life. And this comic strip was created by a palliative physician a few years ago that I think is just such a really cool way. There's a lot of really fun, quirky ways out there to explain palliative care because it is so misunderstood. But this idea that palliative care is the umbrella, not the rain, right? And you could almost kind of say that about hospice too, right? We are not necessarily the problem. You are dealing with a life-limiting, serious, maybe terminal disease. This is additional support. And this idea of palliative care being the umbrella is that it's there when you need it, right? So that you can deploy the umbrella when the rain starts, and that it's there for you. So palliative care is another great service that I would encourage people to check out and see what's available. The Center to Advance Palliative Care, CAPC, CAPC, is a wonderful resource. Getpalliativecare.org is a great resource on not only what palliative care is, but how to find palliative care in your community. So you can search by zip code. It's a great resource and a great way to find out what might be available for you and your clients. Moving on, I want to talk about a couple of other end-of-life options. So, in addition to advance directives and really having the conversation, choosing a surrogate decision maker, Some people also want the option to kind of control their manner and timing of an anticipated death. And there are a couple of ways that a person is legally able to do so. And the one thing I want to mention first before we go into this more specifically is people do have kind of the fundamental right to refuse treatments if it's not something they want. I kind of touched on that a little bit earlier, but just to reiterate, so if somebody doesn't want artificial nutrition hydration, if their body is at a point where they don't feel hunger anymore, we don't have to force feed them. So there is that option, that right to self-determination that is also available to folks. A couple of other options that might be available to people, kind of depending on their situation. One of those is voluntary stopping eating and drinking, or VSED. And VSED is an option that is an intentional choice made by an individual facing a life-limiting illness who seeks to have some control over the manner and the timing of their death. It is a deeply personal decision that we hope is made after really careful consideration of their medical options, of their quality of life, what quality of life means to them, and their personal values. VSED is something that does require careful planning. We definitely encourage people to have a good support system, primarily because there will be symptoms to be managed, and we want to make sure that people are comfortable. And so, having that support in place, ideally, hospice would be great, or maybe a doula. They are really critical in supporting people through that. When somebody is considering VSED, it is something that is meant to be a choice that they make for themselves. This isn't something that can be done to another person. Anything where we are taking action, doing something to a person that results in their death, that is euthanasia. That is illegal in the United States. What we tend to see, what the data shows us, and anecdotally in conversations with folks, the people that tend to choose VSED, one, like I said, these are people that are making this choice for themselves, and they have that desire to have some control over their final days, right? They know that they are moving towards the end of life, and they want to be able to have some control over that. And maybe something like medical aid in dying is not something that they are eligible for or is an option where they live. Usually these are people that they do have a serious illness, but maybe they're outside of that 6 month prognosis. So maybe they have a year, 2 years into expected life expectancy. We do see this a lot of times people living with dementia will choose this. And the reason being that in other or in states where medical aid in dying is an option, you have to have decision-making capacity to choose that. But if you're living with dementia, by the time you reach your 6 month prognosis, they will certainly have lost decision-making capacity. So what we see is people that are living with dementia may choose this option if it feels right for them before they get to that point while they have decision making capacity before they get to that 6 month prognosis. Make
Yeah,
sense? Questions about
I was
VSED?
I was just going to jump in and say one of the things that we can certainly share your way, Jenny, is some of these photos on this slide that Jessica pulled are folks who've shared their stories with us around voluntary stopping eating and drinking. And so we can certainly send along, Cheryl's story or Dan's story for your team to read, because I think we really um, have valued being able to showcase their stories and experiences for why VSED was the right option for them. And hopefully that will also just kind of help give some more context and real humanness behind it for folks.
Yeah,
Yeah.
please do. Thank you.
Yeah. And I think, to the points, Christy, your comment, and Jenny, yours as well. There's a lot of misunderstandings and fear around these because they're not always well explained, not just in our patients, but we have providers who don't necessarily understand the nuance and the differences. And this is where euphemisms, right, can be so dangerous. Christy, to your point. So, palliative care is meant to accompany, and in many cases does, especially for people living with cancer. It's meant to manage those symptoms. It's meant to be that a lot of times they will refer to themselves as an additional layer of support. So it's meant to, not stop any treatments if that's their choice, but to really holistically look at how do we keep this person comfortable? How do we help them have the best quality of life? I mean, as an example, we had a patient where um, she had become very oxygen dependent, and the palliative team was able to get her portable oxygen device, and for the first time in years, was able to leave her home. That's what quality of life meant to her, and that's what palliative care was able to do for them. So, um, so yes, Christy, your understanding is correct that they can help manage symptoms. They can be those care coordinators. They can help deal with insurance in order to get the DME that the person needs or the oxygen, right? All of those kinds of things. And even if hospice were something we were looking at, I think we want to be mindful of this idea of there's nothing more we can do or that we are giving up. We're simply reframing what we're focusing on. And I know that's easier said than done. But really thinking about helping a person um, consider and talk about what matters most to them. Here is a service that can help you with that. So medical aid in dying, you heard me mention that already. Sometimes we tend to refer to this as MAID in shorthand. Medical aid in dying is a medical practice that allows a terminally ill, mentally competent adult with a prognosis of 6 months or less to request a prescription that they can decide to self-ingest to control the manner and the timing of their death. And you heard me emphasize certain things, right? So this is a decision that a person makes on their own. So this isn't something you can put in advance directive and say, when I get to this point, I want my person to do that. Can't do that. They have to be able to administer and ingest the medications on their own. And there are routes. You can swallow it. You can use your feeding tube, your stoma, your even rectal catheter, right? There's different routes, but the individual must take that action to deliver the medication into their GI tract on their own. So whether that's pushing a button, drinking through a straw, it's their choice. So this is a very self-directed, patient-controlled process from start to finish, even to the point where if a patient goes through the process to the point where they have the medications and they choose never to take them, which about a third of the people do, totally fine. That's their choice. Right? Medical aid in dying is in the United States a very specific practice. I think there are some folks that are in other countries, and I just want to acknowledge that the practice of medical aid in dying is not the same as it is in other countries, just as our healthcare system and how care is accessed is very different. And it may have a similar name, it may not, but the practice is very different in other countries. And other countries even allow for euthanasia, allow for people that don't have a terminal condition to access this concept of care. We do not in the United States. So in the United States, what we really focus in on, I'm going to come back to that, is that this is, like I said, for adults over the age of 18 who have a diagnosis of a terminal condition, and they're at that point in their disease where they have approximately 6 months or less to live. They are able to make their own decisions, and this is something that they're choosing for themselves, and that they're a resident of the state where they are making this request. So there are now 12 jurisdictions in the United States, and I say jurisdictions because Washington, D.C. is one of them, and they are not a state. So 11 states plus Washington, D.C. would be another way to say it, where this is an option for folks. Delaware just passed their law. The governor signed that bill just about a month ago, and currently the state is working on the regulations. So we don't have an effective date, but it's coming soon. And if you follow along, or if you're connected to Compassion Choices, you've probably heard that the bill is actually passed both the House and the Senate in New York after 10 years of advocacy and grassroots organizing, public support. It has passed, but now we're waiting for it to go to the governor's desk, and we're waiting to see what she's going to do with it. So we're optimistic that we will soon be at 13. We also have states that are introducing what we call an improvement bill, meaning that we're doing things to expand access, to really help support access. So that could be reducing the waiting period between the two required requests that a patient has to make. We've seen a number of states go from that 15 days in between the two requests down to maybe 48 hours, or even being able to waive it if we feel like the patient might not be able to survive that time. We see a lot of states also expanding who can prescribe. So going from just a physician to now including APRNs, nurse practitioners. So we're seeing that trend. We also work to protect these laws. So we have states, California, Montana, where legislation is introduced to try to invalidate medical aid in dying access for residents. And so we've been working to protect access as well. I do also want to highlight, as mentioned here, that we do have a couple of states that do not have that residency requirement. So in Oregon and Vermont, there is not a requirement that you have to prove you are a resident of that state. Now, what that means is you have to be able to travel to that state, and you do need to be able to kind of stay there through the process and ingest the medications there. This does not mean that you can go to Oregon, pick up a prescription, and hop back home. That's not legally supported and definitely not advised. So, as you can imagine, not everybody is in either a financial or a physical condition to travel, may just not even want to stay somewhere else. So, they might want to be in their own home with their own family. So, it's not an option for everybody, but we do know that this is an option some people are choosing. And I will say that if the New York bill does pass and go into effect, New York does not have a residency requirement either. So that could be another state that does not have that requirement. There are a lot of protections in every medical aid in dying law for the patients, but also for providers. So you heard me emphasize again and again that this is not something that somebody can do on behalf of another, right? This is their choice and a very self-directed process. Also, the laws are all very clear that by definition, medical aid in dying is not suicide. This is not somebody who is wishing to die, right? The people that choose medical aid in dying are living with a terminal illness. They are going to die. And what they're choosing is to shorten their dying more so than they're choosing to shorten their living. And they also are choosing to have a little bit more control over how that goes, right? Maybe they're saving themselves from, kind of pain and suffering that they anticipate. And so because it's not defined as suicide, it is not something that will affect life insurance or other benefits. The death certificate will not list the cause of death as suicide. The cause of death will actually be listed as the underlying disease that is taking their life, not the manner of their death. For professionals, that just because a law exists in a state where you might practice does not mean you are obligated to participate in it. So physicians are not obligated to prescribe. It is absolutely a choice. And physicians, providers, everyone is protected if they choose not to support it. Similarly, organizations, hospitals, healthcare systems, hospice organizations can choose whether or not to support medical aid in dying requests from their patients. And I will say that even if a health system or a hospital chooses to support it, but individual clinicians within that organization don't feel comfortable supporting it, they do have that right as well. Um, what we hope, though, is that regardless of kind of your personal feelings about it, that this is something that, if it is legal, if somebody asks about it, that we are able to give them information, provide them with accurate education on it, and if needed, refer them to someone else that might be able to help them, more with the process. We always encounter situations that we may not necessarily agree with our clients' choices, but we still, offer them that care and support without judgment. So this is very much in that same way. And so, finally, as you're thinking about all of these things, I encourage you to kind of consider for yourself to take some time, to think about what your comfort level is, reflecting on how you feel about end of life options, which of course are influenced by not only the knowledge that we have and our understanding of things, but maybe past experiences that you've experienced, things you've gone through with loved ones, things you've seen, you've heard, but of course, spiritual beliefs, your values, your culture, all of those things come together in terms of what you feel comfortable in, where your limitations are, and what you're willing to discuss or support. So recognizing those limitations, I think, are important. And if you recognize that maybe there is something that you have limited knowledge about, either just acknowledging that and saying, palliative care is not something I know a whole lot about. Let me give you some resources, or let me brush up on that, and then I'll be able to get back to you. And then that way you'll be able to better support your clients. So understanding the legal options in your state. Which of course we can help you with if that's needed. Identifying the policies within your organization or your employer, all of those things. And then, of course, being willing to ask questions and accept that help. So, as we wrap up, and then we'll have some time for questions, I just want to, acknowledge that talking about end of life care can sometimes feel really close to home. It can remind us about things that we've been through. Like we heard today, comments about, things that we've been through with our own family. And we pull from our own life experiences, our own beliefs and our culture, which may serve a client, it may not, right? It may be full of misinformation that we aren't even aware of, right? Or biases that come in. So being aware of our own biases, how do we continue to stay objective and not project our own feelings onto others as they're grappling with decisions and grappling with the end of their life. Um, and then, too often we hear that, these are hard things to talk about, or that we shouldn't talk about things with certain people. Like we're making those judgments that, oh, they're from a certain culture and they don't do that there. Or, this culture doesn't really like talking about end of life. We can't make those assumptions, right? And simply asking a person, is this something you're open to talking about? Opens the door. And you might be surprised that people will say, actually, I really would like to talk about that, because maybe there isn't anyone else in their life that is giving them that opportunity. And that is a really valuable thing that you can provide to them. Of course, I say you don't have to have all the answers, just know where to go to find them. So knowing your resources, knowing what's available to you, I did want to mention that at Compassion Choices, we do have a lot of information on our website. We also offer free resources. And with some of these, such as our End of Life Decisions Guide and Toolkit, we can actually provide you with a supply if that's something that you might want to make available to your clients or hand out. Which is full of worksheets on what are your values, what are your priorities, those kinds of things to help people think about completing their advance directives, talking about what's important to them. So I want to make sure you know about all of those resources, and all of those, of course, are available at no cost on our website. And with that, opening it up for any other questions or conversation or anything I can help with.
Yeah, I was gonna flag that Bethany asked a question that I know comes up for a lot for us or has been asked before, but for medically leading dying, what happens if the
Ah,
person is paralyzed or not able to self-administer? This definitely comes up. Yeah.
this definitely comes up. The second most common diagnosis that we see in medical aid and dying is ALS, and that is a very common concern. And so, we have to look at what the options are, honestly, and what happens for this person. In addition to all of the other eligibility criteria, we do have to look at the ability to self-administer, but also the ability of the body to even take it in, right? So if somebody's got a bowel obstruction and there's issues happening with the GI tract, their body might not even be able to absorb it. If they truly no longer have use of their limbs, they might not be eligible. But for some folks that are paralyzed, if they have other ways that they are initiating movement, if they are using, equipment and technologies that allow them to control the movement of things, that can be an option. So it's definitely something to talk about with the prescriber and the healthcare team to see if there's a way that we can support this person's request. Good question. Anything else?
Megan and Jessica, are there any other links that you want me to make sure I include in the replay for this? Of course, linking over to the website, but I didn't know if there were any other specific ones like last time that I put a bunch of those
Oh,
in there.
thank you.
Thank you. Yeah, I'll send along a couple of our storytellers. Again, those are
Yeah,
I've found, and I think Jessica's seen this too. I found that there's a lot of providers who like to have those maybe to share with people. Like if you want to hear somebody else's story or hear from someone else who's asking these questions. So I'm happy to send that along. We work really hard to try to capture lots of video of our storytellers in their own words. So we've got some great ones we can send your way. And of course, like you said, the web page is great, but I'll also send you like the specific page to our resources so you can get there more quickly because you've got a lot of stuff on the website.
cool.
Is there anything else, Jessica, that I'm missing or that you can think
No, I think that's probably, I think you've got it.
of?
Megan, what was that? The first time you and I met, you were talking about there's a line that providers can call to get support and consultation, right?
Yeah, we have just our general 1-800 number, which we can certainly share. Calls come in and we get them from all people who have questions, providers who have questions, and then
Mhm.
those can get sorted to our team and we can, match you up. And it might be with Jessica or, we have other providers of all kinds that are in our network who take those calls
Okay.
and kind of give peer support.
Yeah.
And so I can resend our little the phone number, but also the email address that goes with it. You don't have to
Okay.
call; it can be an email. Yeah,
Thank you.
Well, thank you again for the time. I know a couple of people had to hop off, but
Yeah.
it was a pleasure being with you. And just know that we're a resource, right? If there are things that come up, a situation you want to talk through, that's what we're here for.
Yeah. Thank you both so much. Megan, will you send the slides to?
yep, yeah. I'll
Okay.
download them as a PDF again and send them
Okay.
your way. Make sure
And
everything's
then
clickable.
Christy's also asking, are there any recommendations you have for clinical consultation?
Can you say a little
This
more, Christy, what kind of consultation you're thinking of? Tell me more.
such a therapist thing.
Um, so I was in a grief consultation group there for a good while, and it just kind of has died. And so I've tried several different avenues with What's Your Grief, a couple of different places looking for consultation. So that's pretty much what I'm looking for because I have the questions about helping people and navigating the difficult topics, the resistance to engaging in palliative care, which I think would be very beneficial, especially because I'm seeing cognitive decline. So those sort of things, how to navigate some of the more difficult topics.
Okay, so are you thinking like grief, loss, bereavement kind of resources, or somebody that can kind of more one-on-one provide emotional support, counseling?
Um, no, for myself, as I help people navigate the end of their life is what,
Mhm.
and so
Ah,
I'm trying to help them kind of basically embrace it instead of resisting. And so the word palliative is like, I hit the brick wall and I said, well, it's kind of like a hospitalist. If you're an inpatient in an ICU setting, you want a hospitalist because they know how to connect you with all the resources.
Yeah.
You can't do that by yourself right now.
Yeah. Yeah.
And so, tips and tricks on how to navigate some of those difficult conversations. That's what I was getting in the group consultation. And so it's kind
I
of lacking now.
Thank you for clarifying. So, I think the best support, we offer is our end of life consultation program, which is our team addressing those, different questions that come up, and we might, like Megan said, you might get me. Depending on the specifics of your question, we might be able to kind of direct things to specific professionals. But that resource is always available to support you as you support your clients,
Okay.
and
Okay.
maybe help with different resources. And then I think depending on, sometimes it's nice to have somebody local too. We might be able to help connect you with some local folks too that can be a resource. What state are you in, Christy?
Tennessee. Well, I'm practicing in Virginia, but the state line runs right down the main street. So Tennessee, Virginia, right in the
Okay.
very tip of the corner. So it's
Okay.
pretty rural, and people are being referred to me. So I hope there's somebody out there, but so far people are calling me looking for assistance.
Okay, so that might be something we can look at too, is, sometimes there are state level organizations, sometimes, there's doula groups that are, organized support, that might be a nice help for you as
Yeah,
well.
absolutely. I would love to get connected to a doula. Yeah,
Sure.
that'd be awesome.
Megan?
Well, that's me. I am one. So that's another
Oh,
thing too on the phone.
okay,
But
good.
only just because my work is also working with doulas across the country. And so I actually know there's like a yeah, there's people kind of scattered across. So that number that I'm going to send and that email address I'm going to send is is kind of our main consultation line. And the only reason, I mean, you could also certainly, email Jessica and I, but that helps us kind of track through the calls we're getting if you're able to go through
Sure.
that normal. But
Yeah.
you could certainly say that you've talked to us directly, and then it'll get to us faster. But
Okay.
we do have, we have folks that we work with who, thank you, Jessica. That's the email address, EOLC. Um, and we can, yeah, get that a little quicker to somebody. But we're happy to, I get calls from end of life doulas who are asking for the similar things, like how do I facilitate this conversation? And then
Okay.
it's usually
Okay.
just time for me to chat through them. And Jessica does that with professionals all the time, as do some of our other EOLC folks who talk
Okay.
through this
Great.
stuff with professionals. We'll role play with you. I mean, whatever you need. So we're happy to do that. So I'll make sure that we send that email address again and the phone number along to Jenny so folks can reach out.
Okay. Thank you so much.
Yeah, and we're also, just for funsies, for extras, we're also, Jessica and our team is in the works to kind of create some new like quick tip like videos and things like that that professionals can again share with folks if they want, or use to brush up for themselves or whatever it may be. And then also I can imagine instances where professionals can maybe share those with their other colleagues to kind of share information and not feel like in your instance, Christy, maybe having to be the one that says, no, this is what it is, and having like another resource that you can share that's
Yeah,
not
that would
just
be
you
awesome.
sometimes helps.
Right.
So
Right. Right.
that's in the works, and we'll be sure when those launch that I can share that with Jenny.
Okay.
And
Great. Thank you
Megan,
so
that
much.
reminds me, we can send the links to the glossary videos.
Oh yes, absolutely. Yeah, we
We
have a
have a
great
series
collection.
of 30, 40-second long videos that define key terms. So there's about 25 different videos. What is palliative care? What is hospice? What is comfort care?
Okay.
What is a DNR? All that kind of stuff. And it's a really easy watch. So that's something we can send you a link to as well. They're all on YouTube.
And
That's
we
awesome.
have them in Spanish as well, if that's of
Yes, you
interest.
do.
Well, so I can send both playlists your way, Jenny.
Cool. Thank you
Okay.
so much.
Thank
You're
you.
welcome.
And Christy, on the 23rd, we have Kelly Doherty, who's doing a train on traumatic grief with us. And I just reached out to her to see if she runs grief consultation groups. I'm not sure if she does or not, but I'll let you know if she does. She's up in New York, I think, but works virtually like me. And so she might or she might have some connections with that. So I can share that with you as
Okay.
well.
Great. Thank you so
And you're
much.
always welcome to bring this stuff to our consultations too. I do not have anywhere near the expertise of these amazing individuals, but I've done a lot of work in a lot of these areas personally and professionally, and so we can at least do our best to talk through things.
Okay, thank you. I really appreciate that.
Yeah,
Okay.
happy to provide support and join any future conversations. If maybe we should start our own group, Christina. You got me thinking.
I know, right?
Hmm,
Hmm.
Jenny.
I know, right? I mean, we were talking about collaborations before we started,
Yeah.
so
We were.
okay, I'm in for it.
Thank you all
All
for
right.
being here and for even asking. Thank you, Christy, for being present for your clients in that way and
Yeah.
wanting to offer that, because I think just being here and sharing with you all is so exciting, because we know just having providers who are aware of this stuff makes such a difference. So thank you.
Yeah.
Yep.
And Megan, I did want to, Megan S., I did want to acknowledge your recommendation. BJ Miller's awesome. He has a really great TED Talk. And he is he's a palliative physician extraordinaire. Not a supporter of medical aid in dying, although he's in California. Ira Byock is also another one that I would recommend. And oh my gosh, yes, a tool
Being mortal.
not only the book, but there is a documentary on being
Mhm.
mortal. I used to make it required viewing as part of orientation for all my hospice staff that I would bring on. Really awesome. I highly recommend that. I think it's just available online. But A Tool God on Monday's documentary is wonderful. Ira Byock has, if you watch The Pit, actually he was a part of that. He has,
Ah,
kind of the four main things: that I love you, I forgive you, that kind of thing. And that's also a really great recommendation of content there. He's
okay,
also a palliative physician here in California.
I just
cool.
dropped Ira's website in the
There you
chat,
go.
Jenny, if you want to share that, because
Thanks.
it also has his books and all that stuff on his website.
Yeah. Yeah.
Cool. All the
All right.
resources. All right,
All right.
everyone.
Thank
Thanks,
you so much.
everybody.
Thank you. Take care. Have a good weekend,
You
and we'll
too.
talk
Same.
soon.
Yes.
Same.
Okay.
Thank
Thank
you.
you.
Bye.
Bye.